These are the presentation outlines. Nowadays, actually, it's very difficult to speak about satisfaction in this section, dissatisfied world. But there are so many beautiful souls who serve the traumatized populations. So we have here to talk about those beautiful souls who serve the traumatized populations. How those populations feel their satisfaction while serving those traumatized clients. So, as you know, compassion satisfaction is a profound sense of fulfillment and meaning derived from underlying aiding source image. This compassion satisfaction is a feeling which is we feel while we are serving those individuals. It represents a positive, rewarding aspect of caregiving and professional. The second one is compassion fatigue. This we can define as compassion fatigue as excess of emotional and physical exhaustion combined burnout and secondary stress, often experienced by professionals exposed to trauma. So this is, we can say that compassion satisfaction can be considered as the inverse relationship with compassion fatigue, and also compassion fatigue can be combined burnout and secondary traumatic stress. So reported prevalence rates and correlations between those states vary widely across studies. So we were interested to analyze those inconsistencies and highlight the need for meta-analytic synthesis to clarify those crucial professional outcomes. So our research objective was to systematically synthesize global quantitative studies on compassion satisfaction levels among humanitarian and social service workers. And the second one is to analyze those correlations between compassion satisfaction as well as those adverse outcomes, including compassion fatigue, burnout, and secondary traumatic stress. Here at Matrix, we have been following to analyze this correlation and meta-analysis. So we have been following the Prisma guidelines prospectively registered on Prospero guideline, and compressive search across compressive search strategies were performed using permeate generic science director as well as scientific semantic scholar databases, and observational studies of humanitarian and social service workers were included. Qualitative, low quality job by 50%, as well as arbitrary articles were excluded. And data analysis, data synthesis, we have identified 44 studies met the inclusion criteria and were synthesized using random effects for data synthesis. This is the Prisma diagrams, which have been following in order to identify those studies which has been included in meta-analysis. These are some little bit, as you know, as we have said before, we have included around 44 steps to meta-analyze the correlation between compassion satisfaction as well as adverse outcomes of professional quality of life. So we have extracted the data, their country, study population, sample size, gender, mean age, experience years, outcomes, since the compassion satisfaction has been extracted using mean score as well as their proportions. So this the main outcome of this meta-analysis was compassion satisfaction level, which has been measured using mean score as well as proportion, right? So this compassion satisfaction has been reported in proportion, low, medium, or moderate, as well as high rate, as well as mean score. So around 10,926 participants were involved in meta-analysis, as well as this meta-analysis encompasses around 15 countries represented across the globe. So these 44 studies were extracted around 15 countries across the globe. So 38.4 years full image. In general, a majority of the study participants were parent participants. Here, meta-analytic insights reflect a moderate level of work-related fulfillment among humanitarian and social service workers, around 36.13 minutes for compassion satisfaction. So when we see the levels of professional, compassion satisfaction, which has been reported in levels, as well as low satisfaction, satisfaction, moderate satisfaction, as well as high satisfaction. So around 16% of those study participants were feel a low satisfaction or a low compassion satisfaction, as well as 47% of those study participants feels moderate satisfaction as well as high satisfaction. Those 43% of those individuals who has been included in this meta-analysis feels high compassion satisfaction. All of the studies has been measured using proportional factor of life scale. So compassion satisfaction, this is the first plot which is showing the pooled mean compassion satisfaction score among humanitarian and social service workers, which is been around 6.13 mean score. The next one is the results and discussion parts, which is compassion satisfaction and its correlation with adverse professional factor of life outcomes, including compassion fatigue, compassion secondary traumatic stress, as well as burnout. So there was a weak negative association between compassion satisfaction as well as compassion fatigue. As I have said before, compassion fatigue is a long-term experience of parents which has been serving those individuals who feels traumatized. So there was a weak negative association between compassion satisfaction as well as compassion fatigue, which is a z-score of negative 0.25, which means we have extracted the correlation Pearson R in every studies, and those correlation R scale has been converted into Fisher's z-score, and those Fisher's z-score numbers have been back transformed into Z for final interpretation. So there has been a subgroup variation significant, and analysis by continent and occupation did find significant between group differs, failing to explain those sorts of high variability. There has been reported a significant and high heterogeneity between group studies, and we have performed different subgroup analysis using continent, occupational groups, sample size, professionals, that type of profession. So we were able to identify those variabilities when we were performing subgroup analysis. And the next one is there was a high correlation between burnout as well as compassion satisfaction, which is Fisher's put z-score of negative 0.05, 0.55, which is means high or a strong negative correlation between compassion satisfaction as well as compassion fatigue, meaning there is, if an individual has a good compassion satisfaction score, may face a less burnout mean score. Actually, as you know, it's very difficult to define using this correlation as a placebo effect on those outcomes, but we can simply say that in a surface way, they are positive as well as negative correlation between those positive as well as negative associations. So contextual variability, there was high heterogeneity, as I've said before, indicates significant variability between the group stage. This underscores the need for subgroup analysis to explore how regional or professional differences as well as different analysis has been done in order to identify the source of this external heterogeneity, but we are unable to identify in where this source of heterogeneity was. And there was a weak correlation with between compassion satisfaction as well as secondary traumatic stress. As I've said before, this secondary traumatic stress is a type of work-related stress which has been experienced by those professionals which can be considered as which those individuals as feels or experiences indirectly because of serving those traumatic individuals. So there was a weak correlation between this compassion satisfaction as well as secondary traumatic stress. There was negative 0.15, put Fisher's z-score, and analysis reveals a small but significant inverse relationship, indicating this satisfaction was limited protective against secondary traumatic stress. This analysis shows the three adverse professional outcomes, which is called compassion satisfaction and compassion fatigue, and compassion satisfaction in burnout, as well as compassion satisfaction in secondary traumatic stress. We can conclude that this positive aspect of satisfaction has an inverse relationship between those adverse professional quality of life. Even though the relationship can be negative or positive, we can conclude that there is a negative correlation between compassion satisfaction as well as the three adverse professional quality of life. The figure showing the correlation between those three outcomes. And we have also performed the PT on burnout as well as compassion fatigue and burnout with secondary traumatic stress. As you know, burnout with compassion fatigue as well as burnout with secondary traumatic stress had a positive correlation between those adverse professional quality outcomes, and a strong positive correlation because significant overlap between reduction in exhaustion and reduced empathy and burnout and traumatic stress. A strong positive association suggesting that workplace burnout heightens trauma-related symptoms. We have also performed a subgroup analysis, which is divided into America, Europe, Asia, Africa. So having said that, I think it's very difficult to conclude within this classification as far as those studies which have been included. Each continent is maybe small in number, so it's very difficult to generalize those subgroup analysis into four. But for example, let's say in those studies which has been included in Africa, maybe 3 or 4, so it's very difficult to generalize the compassion satisfaction score as 36.8. But we try to identify the source of unexpected heterogeneity by using those subgroup analysis using which. And we have also performed a subgroup analysis to identify the source of heterogeneity using occupation as humanitarian workers as well as social service workers. We identified a 36.99 minutes score of compassion satisfaction among social service workers. This because there may be humanitarian aid workers has an exhibited lower compassion satisfaction when compared to social service workers. There may be an increase in operating under resource. As you know, this resource, there is a resource limitation in conflict affected areas. There may be uncertainty, high traumatic environments, compounded by ambiguous role boundaries. There may be a role of ambiguous complexity on these professionals. So, because of those reasons, there may be different compassion satisfaction score. Having said this, we try to identify the robustness of our synthesis using the one analysis. So, an scale value of 100% was observed in the pooling with compassion satisfaction score, and there is, as I have said before, there was limitations of the analysis, which were able to identify the source of heterogeneity. So, the robustness of our analysis has been affirmed by using Lee-One analysis and showing no study, single study, disproportionality influenced the results. This meta-analysis or correlational meta-analysis has been supported by different studies. Let me conclude in 1 minute. Thank you. This meta-analysis or correlational meta-analysis has been supported by different meta-analysis, which has been across professions, which is among nurses, healthcare providers. However, the current time was lower than that of another meta-analysis in nursing, which was for 7.55%. And potential for growth, this is a conclusion, and encompasses vital protective factor mitigating burnout and secondary traumatic stress among those professionals supporting traumatic individuals. This was our recommendation. strengths and integrate compassion metrics in the routine compassion satisfaction assessment into organizational health monitoring, strengths and peer support, trauma-informed supervision, has been recommendation. Thanks.
Good afternoon, everyone. My name is Gabriel Yetu, from University of Rwanda. I will present my article entitled with Gender-Based Factors of Gender-Based Violence and Women and Girls in Africa. This is a review of review. Here is presentation outlines where we come the background section. Gender-based violence is any harmful act that affects individuals against their will. It comprises physical, sexual, psychological, emotional, and other violences. It is a widespread global public health and human rights issue, and it affects millions of women and girls due to the intersectionalities of gender, age, and emergencies. According to the WHO 2024, gender-based violence affects about more than 33% of women and 77% of the survivors developing mental health problems like that of depression, anxiety, and post-traumatic stress disorder. The occurrence of the problem is intensified in Africa due to the low resources, the enormous conflicts, and the displacement and others. This gender-based violence impairs the achievements of sustainable development goal, which targets eliminating all forms of violence in 2030. Published systematic review and meta-analysis across African countries shows the fragments of studies. So we were able to synthesize this inconsistent findings to pull one. This study is an important aspect towards achieving the sustainable development goal target of eliminating all forms of violence against women. Like I said, this study informs future scientific, therapeutic, and policy discussions on gender-based violence and its contributing factors. Here is objectives. The general objectives is to synthesize the magnitude and associated factors of gender-based violence among women and girls. The specific objectives are the first one is to estimate the magnitude of to estimate the prevalence of gender-based violence, and the second specific objective is to identify the factors that affect gender-based violence. The method session is the study design is a review or review of reviews. The study area is Africa. The study population is women and girls. The sample size is 682. 1,280. The data collection and analysis procedures we have used Microsoft Excel and Stata 17 softwares for data extraction and comprehensive analysis respectively. The study followed the PRISMA 2020 guidelines and was registered in Prospero. Databases such as PubMed or Medline, Science Direct, Type-Info, InViz, Scopus, African Journals, Online, and others for great literature were searched between May 25 and June 2025. The studies of the systematic review and analysis of gender-based violence in Africa, regardless of the publication year, were included. The meteorological quality was examined using Amstrad assessment of multiple systematic reviews and analysis of quality tool. Heterogeneity and publication bias were assessed. Subgroup and sensitivity analysis were done, and associations were reported with statistical significance. at P less than 0.05. We identified 1,987 citations and duplications were detected and removed with Indirect theory software. Titles, abstracts, and full texts were screened and ultimately theory 3 systematic review and meta-analysis were included in the final analysis. This is the Prisma flow chart or the Prisma flow diagram. This is it comprises databases with subsequent numbers of articles, and this is the process of selection, and finally we have included the theory 3 systematic review and meta-analysis articles. This is a descriptive summary of the included studies, the theory 3 systematic review and meta-analysis, which includes the outer year, the study area, study population, number of studies, sample size, the prevalence, forms of the gender-based violence, perpetrators, and status for which this confidence was summarized. The lifetime prevalence of gender-based violence in Africa was found to be 38.74%, with an I-square of 97%. This indicates Africa is far from achieving the Sustainable Development Goal 5. This study is, the current study is consistent with other reviews, as the WHO global and regional estimates and other studies, so systematic review and meta-analysis. And the current study was higher when compared with others in China, Asia, and Europe. The possible justification for the variation could produce the information about the heterogeneity and the others we have with random effects testimonial model. The total prevalence of sexual violence was found to be 32%. Physical violence is about 29%, and the psychological violence was found to be about 33%. Since there is heterogeneity, we have used subgroup analysis. Subgroup analysis based on the target population, the highest or the greatest prevalence was observed among students at 50%, and subgroup analysis based on the study setting, the highest prevalence or burden was found in Ethiopia as 41%, and subgroup analysis based on based on the perpetrators, also gender-based violence performed by both IPV and NIPV is the greatest, as 43%. Anyone sensitivity analysis also was used. There is no single study effect outside of the pooled summary effect. So this indicates the robustness of the study. And also publication bias was assessed both objectively and subjectively. As evidenced from this slide, there is no indications of the publication bias. The final plot, there is an uneven distribution of studies or symmetrical distribution of studies in the right and left sides of the pooled summary effect. So this indicates the absence of publication bias, and the reverse test with the objective one is statistically insignificant. Also it indicates the absence of publication bias. So there is no need of doing trend field analysis. We have also summarized for the factors or the predictors. There are different factors associated with this gender-based violence. This one is residency. So those women and girls who lived in rural areas were 2 times more likely to affected by gender-based violence when compared with those women and girls living in urban settings. And the other one is education. This one is alcohol, and this one is child or all other risk factors for the society. Perpetrator-related factors were also summarized. The first one is educational status. Those perpetrators who have no formal education are almost 1.5 times more likely to commit gender-based violence on the woman when compared with those with formal education. The other is alcohol usage, and this is decision making capacity or as risk factors. Where we have the conclusion, the prevalence of gender-based violence, including all forms, physical, sexual, and psychological, was found to be high. Besides the survival-related factors like that of residence, level of education, use of alcohol or child and perpetrators' education, alcohol use and decision-making power were significantly associated with gender-based violence. Therefore, an interministerial collaboration is needed for legal expansion, survival support services, and other the future incidents of gender-based violence. The Ministries of Education should launch community-based adaptive literacy programs in rural areas by prioritizing women and girls with formal education. The judiciary shall strengthen the enforcement of the gender-related laws, and the regional bodies like the African Union, the United Agencies and NGOs shall develop continental gender-based violence surveillance system, shall prioritize funding for this program for prevention. The Ministries of Gender and Women Affairs should launch community-based programs targeting rural women, and it shall promote women's decision-making autonomy. The Ministry of Health shall give training for healthcare workers and shall integrate gender-based services into the primary health care and substance use programs. Where we have the acknowledgement session, heartfelt appreciation to Amara Tropical Institute, Bahada University, my working institution, University of Golden, and all authors of the articles included in this review. Thank you all for your attention and time.
Good afternoon. Daniel Panado, ከዚህ ከባህር ዳር ዩኒቨርሲቲ ነው። Okay, sorry for interruption. My research title named as Determinants of Neonatal Mortality, Neonatal Illness among neonates admitted at Bahar Dar City Public Hospitals in Bahar Dar, North Ethiopia. The outline corporates introduction, objective, methods, results, based on results and expressions, we will conclude and recommend concerning bodies, and finally, acknowledgement. Neonatal near miss refers neonates who are newly died but survived by chance or by medical interventions that are after 28 days of life. And the Center of Latin American Neonatology and the Pan-American Health Organization developed standardized criteria, management criteria, the so-called pragmatic criteria and management criteria. From the pragmatic criteria, neonatal illness are defined if either from the pragmatic or the management criteria, አንዱን የሚያሟሉ ከሆኑ either birth weight less than or equal to 1.75 kilogram, Apgar score less than 7 at 5 minutes, gestational age less than 33 weeks, and management criteria. From these criteria, አንድ criteria ካሟሉ neonatal illness እንላቸዋለን ሲሉ American Center of Perinatology እና
ፓን አሜሪካን ኦርጋናይዜሽን የክራይቴሪያ አውጥተዋል። እንደኛ ሀገር የለንም። When it comes to the statement of the problem, እንግዲህ global international magnitude of neonatal illness, as you see from this to here in ደብረ ታቦር ኔፓል ላይ የሚያሳየው 2.2% ነው የኒዮናታል ኢልነስ በርደን ማለት ነው። የደብሊውኤችኦ ማልቲ ካንትሪ ስቴት ኦቨርኦል ስቲሜት ያደረገው 7.5 ነው። ወደ እኛ ሀገር ስንመጣ 14% ኦልሞስት የዚህ ሬፕሊኬሽን ማለት ነው፣ ወይም ደግሞ የዚህ ጥፍር ማለት ነው። ዘን ወደ ክልላችን ደግሞ ስንመጣ ይሄ እንጅባራ አካባቢ ላይ የተሰራ ፕሮሴክሽናል ስቴት የሚያሳየው ነው። ወደ ደብረ ታቦር አካባቢ የተሰራ ጥናት ደግሞ ይሄን ያሳያል ማለት ነው። ሰው እዚህ ላይ የምንረዳው ነገር ምንድን ነው? ከግሎባል ወደ ሎካል በመጣን ቁጥር የኒዮናታል ኢልነስ ማግኒቱድ በጣም እየጨመረና ሲግኒፊካንት እየከፋ የሚያመለክት ሲግኒፊካንሱ እንግዲህ በጣም በርካታ ጥናቶች በተለይ ኒዮናታል ሞርታሊቲ ላይ የቀረቡ ጥናቶች አሉ። ሶ ይሄ ኒዮናታል ኢልነስ መካተቱ እንደ አንድ ኮምፕሊመንተሪ ኢንዲኬተር ይሆናል ብለን ነው የምናስበው። and continuous to achieve the SDG goals, which is good health and well-being and the service as a design data for future researchers. This is the conceptual framework. Totally we have 6 independent variables, the so-called health system related factors, obstetric and reproductive factors, social demographic factors, maternal and medical condition, pregnancy, and behavioral factors. The objective is to identify the determinants of neonatal mortality in Bahar City public hospitals. When we come to the method section, the study area is in Bahar City, and the study design and the period are a hospital-based unmatched case control study has been conducted. The study population cases newborn with at least one of the neonatal illness identification criteria, like pragmatic and management criteria ናቸው። ከነዛ አንዱ ካሟሉ ኬዝስ ስለመስናቸዋል። ኮንትሮልስ ኒዮኔት ዊዛውት ኮምፕሊኬሽን are admitted the postnatal or neonatal ward for postnatal care by health care providers በፊዚሻንስ ኦር በኒዮናቶሎጂስት ወይ ኮምፕሌክስ ኬር ፕሮቫይደርስ ሪስክ አላቸው ተብሎ ዲክቴት ያደረጉ ማለት ነው። እንደ ኮንትሮል ወሰናቸው። ኢንክሉዥን ክራይቴሪያ ኒዮኔት were admitted at selected hospitals with at least one neonatal illness identification criteria. And the controls were units were admitted to the postnatal ward. Exclusion criteria those units whose mother was dead, ሶስት ዩኒቶች ኤክስክሉድ አድርገናል። 2 units 7 ያክል units are born at home or on the way to the facility, and those units referred from another health facility. እንግዲህ እነዚህ የሆኑበት ምክንያቱ አናውን ክራይቴሪያውን ዲፋይን ስናደርግ ኬዝ ለማለት አናውን ካረንት ስታትስ ላይ አፍተር ስቶሪ ብዙ ወይ ዲፋይን ማድረግ ስለማንችል ኤክስክሉድ ያደረግናቸው ቫሪያብልስ ኒዮናታል ኢልነስ የስ ኦር ኖ የሚል ዲፔንዳንት ቫሪያብል ይኖራል። and 6 independent variables. and the data collection tools primary interview አድርገናል እናቶችን and charter was like progress note, discharge summary, and history has been taken. Investigation ታይተዋል ማለት diagnosis and data management analysis cleaned and coded using already collected ነው ኮሌክት የተደረገው። CSCS version 26 was used and the binary logistic integration has run and the model fitness checked and the p-value taken at p0.05 ወደ ሪዛልት ስንመጣ እንግዲህ ሊፍቱ 443 ፓርቲሲፓንትስ ናቸው ያሉ 147 ኬዝስ and 296 ኮንትሮል 1:2 ነው ሬሽዮ የኬስ ኮንትሮል። So 100% ሪስፖንስ ሬት ነው የነበረው። ኒርቱ ወደ 65.3 ኦፍ ኬዝ ሄዝ ማዘር had no formal education compared with 28% of controls. And nearly 2/3 of cases were from rural areas, whereas 64.5 of controls were urban. ወደ እነዚህ በጣም ኢምፖርታንት ቫሪያብልስ ናቸው ከናፕሬሽን ሂር obstetric and reproductive health factors. Any follow-up during the current pregnancy were reported by 58.5% of cases and 90.2% of controls. The history of pregnancy with hypertension was reported among 70.7% of cases and 53.7% of controls. Among these mothers with premature rupture of membrane, all units were cases. this is scientifically plausible. Premature mature of milk ለብዙ ለሴፕሲስ premature labor ስለሚያጋልጥ ማለት ነው። And regarding the onset of labor, induced labor 58.5% of cases versus 11.5% of controls. And the spontaneous labor 41.5% of cases versus 88.5% of controls. Maternal medical condition during pregnancy, 75 or near to 50% of cases were born to mother with history of diabetes mellitus, but no controls reported. ወደ ኒዮናታል ሊሚስ አይደንቲፊኬሽን ክራይቴሪያ ከደቃናቸው ከስምንቱ ክራይቴሪያዎች በጣም ሃይሊ ሪፖርት የተደረገው ዩዝ ኦፍ ኢንትራቬነስ አንቲባዮቲክስ ነው ዲዩ ቱ ዲፈረንት ሪዝንስ ፓሬንታል ኒውትሪሽን ዩዝ ኦፍ አንቲናታል ስቴሮይድ ናዛሲፓፕ ዩዝ ኦፍ ኮርቲኮስቴሮይድ እንደዚህ ሊስት ዋን ጀስቴሽናል ኤጅ less than 33 weeks. When we come to health system related factors, these are two factors were appreciated: waiting time before treatment are received and the particular utilization. As you see here, among mothers followed by not followed with partograph, where only 8% of controls were reported, while 111 of among mothers who not followed with partograph. And nearly 100 among 150 mothers who were taken less than 120 minutes, only 60 cases were reported. When it comes to behavioral related factor, delayed of breastfeeding was reported in 7.5% cases and 33.4% of controls. Among this much of neonates, 85.7% of cases and 59.9% of controls were breastfed fewer than 8 times per day. Recommended develop rates ስለሆነ ማለት ነው። And these are the determinants of neonatal illness findings. For variables or factors were identified: explicit breastfeeding within 1 hour, pregnancy-induced hypertension, and its follow-up and the travel time to the health facility with this adjusted ordination. Discussion. This study significance those neonates born to women who have fewer than 4 NDTs had 8.3 times more likely to experience neonatal illness than their congruent. And this finding is congruent with this stage, like it's obvious that if pregnant mother adheres to NBC, especially early initiation of NBC follow-up, to avoid preventable risks and registration of the treatment. And this may be explained by the fact that complete NBC influences the maternal continuum of care, thereby affecting the neonatal outcome. And similarly, the odds of neonatal illness were 5.55 times higher among neonates born to mothers with pregnancy with hypertension. And they line with previous studies conducted in Ethiopia and Africa as well as in Brazil. This may be due to the fact that hypertensive pregnancy impairs placental development, that is placenta insufficiency and thereby preterm birth and other complications. Consequently, it increases the risk of neonatal illness. However, this finding is incongruent with the study done in Hawassa. There is a responsibility due to the difference data source, sample size, and the study design. The Hawassa only they take the secondary data alone. Neonates born to mothers who traveled more than an hour had 6.55 times higher odds of neonatal illness. This is evidence is consistent with these studies. It is scientifically known that proximity to health facility enables timely, appropriate, and biased providers improving maternal and neonatal outcomes. This finding identifies that neonates who delayed initiation of exclusive breastfeeding, or that means more than an hour, were 3.13 times more likely to experience neonatal illness than their counterpart. And this study is consistent with studies conducted in different areas, including Rwanda. And this is plausible scientific fact that early initiation of breastfeeding leads to neonates, maternal antibodies, lactoferrin and oligosaccharides, other protective components of breast milk that improves neonatal immune function. As a limitation, as we develop countries, neonatal milk definition represented in the place. For example, precision measurement of gestational age, and then measure the ultrasound like that. ሌላው ቶሎም አይጀምሩ አፕሪሼት አይደረግም ሰው ከ33 ዓመት በላይ ናቸው በታች ናቸው ለማለት ቢያዝ ሊያደርገን ይችላል ስታንዳርድ ስለሌለ ማለት ነው። እንደዚህ ስቴትመንት ኤሊሚኔት ፓስተርስ ዘ ኮንዲሽን ኦፍ ኒዮኔት አፍተር ዲስቻርጅ ዱሪንግ ዲስቻርጅ ነው ዳታ ኮሌክት የተደረገውና ፌታቸው አፍተር ዲስቻርጅ አይታወቅም። እንደዚህ ኒውስ ፕሮስፔክቲቭ ኮርስ ሊፈልግ ይችላል ማለት ነው። Conclusion, pregnancy hypertension, which has facility for home, and then early initiation of exclusive breastfeeding, determinant of neonatal illness, among this, having pregnancy with hypertension, and which has facility from home, where the determinant is high cost of neonatal illness. As recommendation, Minister of Health expected to develop standardized local adapted neonatal illness case identification criteria. Amara region strengthens ambulance and referral service to improve access and to care. Care providers promote complete NEC attendance and preparedness and complication readiness plan implementation line. These are promoted issue detection and management of pregnancy-induced hypertension. And counseling. As a researcher, conduct prospective longitudinal study on post-discharge neonatal outcomes. Ethical consideration has been assured and acknowledgement by the University, American Institute and National Healthcare Initiative policy. These are some references. Thank you for your interest.
My name is Leo Tadam, and I will be presenting from Norway University, and I will be presenting on University Quality Contraceptive Counseling and Contraceptive Satisfaction and Interview Switch among contraceptive users in Ethiopia using generalized structural equation model. These are the outlines. Quality contraceptive counseling refers to the quality of care given to a woman during family planning visits. The acquisition of quality contraceptive counsel is a human right that helps the client to obtain informed, autonomous, and respectful contraceptive decision making. However, contraceptive counseling faces different challenges such as disrespectful, being driven, provider driven, and lack of information. The quality of quality contraceptive counseling is linked to contraceptive method satisfaction, contraceptive side effects, and contraceptive method switch. Due to lack of quality contraceptive counseling, an estimated 74 million women in low-income countries experience unintended pregnancy. Around 37.4% were planning either to change or to discontinue their contraceptive method. Among modern contraceptive method users, 40.2% discontinue because of the side effects. And this lack of quality contraceptive counseling lead to the loss of trust on the health system. This quality contraceptive counseling plays a major role in maternal and reproductive health rights and affects the sustainable development goal of 3.7. Universal access to sexual and reproductive health care service by 2030. So the rationale of this study is also the quality contraceptive counseling was validated in a study done in Addis Ababa, Ethiopia. Empirical evidence of quality contraceptive counseling constructs in large and diverse populations and the influence of these constructs on women's mental satisfaction continuation remains limited. A general structural equation model approach is justified for this study because it allows simultaneous assessment of the family planning continuum. That means from constructs and from quality contraceptive counseling, obtained the desired contraceptive method, contraceptive effects, contraceptive method satisfaction to finally the switching intentions to their current contraceptive method. So this is called the family planning continuum. So this model helps to model all of this simultaneously. So, serial period, so the PMA Ethiopia was a 5-year project implemented through partnership between Addis Ababa University, John Hopkins University, and the Federal Ministry of Health, which is funded by Bill and Melinda Gates Foundation. So the project is focused on reproductive, maternal, and newborn indicators. So the study was used to PMA 2026, which is collected between November 2023 to January 2024 during the time of armed conflict on different parts of the country. So the study science committee is a cross-sectional study and the source population were all reproductive age women aged 15 up to 49 in Ethiopia 2023, whereas the study population is all reproductive age women who were contraceptive users in 2023. So the eligibility criteria women aged 15 up to 49 years old who were contraceptive users during 2023. Regarding the sampling size, there were 8,947 women who completed the PMA 2023, and among these 2,300 were contraceptive users. Amongst contraceptive users, 2,178 were assessed for quality of contraceptive counseling. And after data cleaning of missing data and our results, finally 2,139 participants were included in the final analysis. The sampling taken to two-stage cluster sampling was used first as a mining region strata, then classified, stratified using urban and rural. The indigenous variable services, the outcome variables in the world, so quality of contraceptive counseling obtained with the contraceptive method, contraceptive side effects, contraceptive method satisfaction, intention to switch contraceptive method, measurement indicators for QCC, since QCC is a latent variable, so these are the constructs. There are 12 constructs to measure the quality contraceptive counseling, that's felt encouraged, no interruptions, ask questions, receive information, give time, understand reaction, that means for the contraceptive method, understand usage of the contraceptive, give opinion about the contraceptive usage, felt pressure by the supervisor, felt scolded, felt listened, and felt discouraged. These are the 12 constructs. And the other exogenous, that means variables with age, at first is contraceptive, educational status, wealth, content, marital status, religion, and residence. There's also exogenous has service-related variables that are types of facility, prior family planning experience, fees for medical card, fees for supplies, fees for contraceptive methods, transport risk and duration of contraceptive use. And operational definition, so there are 12 constructs, but some constructs are should need to reverse the code since it is like a from strongly disagree up to strongly agree. So mostly the abuse and disrespect indicators are negative questions. So we have reverse code. These are felt pressure, felt scoring, felt scoring were reverse code. So that the higher value indicators, that means the better abuse and disrespect. That means the others are not abuse and disrespect. Data management data was cleaned and prepared for analysis. Descriptive statistics was conducted accordingly for the variable scales. Explanatory factor analysis was first conducted, then reliability testing was conducted, and confirmatory factor analysis, and finally structural equation modeling was conducted. Survey designs such as clustering and sampling weights were also incorporated in the analysis. This is the theoretical framework how the variables interact with each other. That's were kind from previous studies, so it's not that much clear, but there are abuse and disrespect items, the failed pressure, failed scoring, failed scoring, also information exchange domains, the failed asked questions, receive information, understand reaction, understand decision, give opinion. And there's also interpersonal relationships, also failed to correct, no interactions, give time, and failed to listen. These are in green, in yellow, the latent variables, where the outcome variables. So since it's not visible, I proceed. So the result in discussion parts, there were 2,139 participants analysis and never attended, comprised 21.7, primary education 46%, secondary education 19.6, technical and vocational 4.3%, and higher education for 8.4 were comprised educational status. Wins content, the service loss content, wins content 40.2, lower wins content 15.5, middle wins content 15.5%, higher wins content 20.3, and the highest content were 29.5%. So among the respondents, 42.2 were urban residents. Among the participants, 46.6% were not asked about their previous family planning history by healthcare provider. With respect to contraceptive method, 50.6 took injections, 36% took implants, 8.3 took pills, and the other 5.9 took other contraceptive methods. That means lactational aminorated IUD minerals. So there are 12 indicators, and these indicators are grouped into two. We go to this one. That means it's called exploratory factor analysis, how the components interact to each other. So even though there are in previous studies there are 3 constructs in our finding, we have found 2 constructs. That means these 9 items were in the first one. That means information interrelational domains were loading factor 1, and factor 2 were the disrespectful one, that is the pressure to discouraged were on the factor 2, and the other one, the other 9 items were loaded the factor 1. So we have 2 volumes total. And this one is confirmatory factor analysis, how these constructs measure our outcome variables, that means quality contraceptive counseling. So as you see, all of the variables has factor will be greater than 0.56, which is good. And also the other domains, that means the root square also less than 0.08, and also CD also square is greater than 0.9. So these proper constructs measure quality of contraceptive counseling way. And this is the model, total final model after the best fitted model of our final outcome, our variable, that is, so the 4 outcome variable, and these are the 9 variables loading on information and interpersonal variables. So since it's not clear, let us go to, we represent this one using a table. On the health facility type, the private clinic and private pharmacy are less likely getting information interpersonal QCC domain. And also, on private clinic, private pharmacy, they are less likely to get information interpersonal quality of care, but they are more likely to get their desired contraceptive methods, which is contract idea. And private clinics, they should take their family contraceptive method from private clinic and private pharmacy are more likely to switch their current contraceptive method. So this is because public hospitals and healthcare centers often follow national guidelines, have client providers, and are subject to supervision. In contrast, private clinics and pharmacy may not get continuous training, prioritize efficiency or product sales, lack of counseling protocols, and have limited time and privacy and counseling. So as you see, these are the coefficients, that means because these are the latent variables that are continuous variables. So if it is the value is 0, That means if it's greater than 1, that means positive and less than 1. Then less than 0 is negative, whereas the other ones are all in this ratio, so the values are 1. So, but for this one is the value 0, so you have to understand that better. The other one is contraceptive method type. Those who use implant are less likely, those who use implant are less likely get their obtained desired contraceptive methods than injections. And also other ones is because maybe implants can cause regular bleeding or discomfort compared to injections. And also information and interpersonal domain. That means more quality counseling or information and interpersonal domain leads to more likely getting their obtaining their contraceptive method, more likely to have method satisfaction. This is because contraceptive counseling is clear, accurate information, and clients are more get their choice and satisfied. And the other one, abuse and disrespect. Those who are less likely to abuse and disrespect are get family more likely find their obtained desired contraceptive and more likely to satisfy. This is because fields are respected and contraceptive counseling plans are more likely to trust the method and find obtained those who find family obtained desired method are more likely to develop side effects and more likely to satisfy and less likely to intention the contraceptive method. And the other one is experience side effects. Those who have more side effects, those who develop side effects are less likely to satisfy and more likely to switch their contraceptive method. And method duration, those who take the contraceptive method for long duration are more likely to satisfy. And also this those who are satisfied with their contraceptive method are less likely to switch their current contraceptive method. And at first contraceptive use were less likely to switch their current contraceptive method. Okay. And also ask about their prior contraceptive. Those who are asked about their prior contraceptive method are more likely to get quality contraceptive counseling. And those who are educational status are more likely to get contraceptive counseling and less likely to get abuse and disrespect. And then finally, there was contact. Those who have come from the richest household, more likely to get better contraceptive counseling. So the service and limitation, a comprehensive national overview of contraceptive experience in Ethiopia. The application of both exploratory factor analysis and confirmatory factor analysis, and also the study assesses the comprehensive family planning quantum of care, starting from the quality, the counseling up to the switch intentions. And also the study also has some limitations regarding to some conforming values like product characteristics were not found, and also cultural and social norms were also found. The toxic quality contraceptive counseling has two elements: the information and interpersonal domain, and the other one is abuse and disrespect domain. The quality contraceptive counseling domain is associated with marital status, quality, wealth quantity, educational status, prior experience, and facility type. And also facility type, quality, contraceptive type, and cases were associated with obtaining the desired contraceptive method. Those who obtained desired contraceptive was associated with contraceptive side effects, and contraceptive method satisfaction was associated with contraceptive side effects. Quality contraceptive counseling obtained desired method in method duration. Contraceptive method switch intentions were affected by facility type obtained desired contraceptive method. Contraceptive side effects, contraceptive satisfaction by the first use. So finally, the combination interpretation reflects to strengthen operation of women-centered counseling, pays special attention to private pharmacies and clinics. Family plan providers equal to asking every client about their prior contraceptive experience. This allows for more effective counseling and enables family providers better identify common side effects and communicate with them. It's crucial to ensure consistent and diverse supply of contraceptive methods. It is important to disseminate easily understandable information and education for clients to address literacy level of the participants. I acknowledge the PMA 2023 data contributors. So thank you so much.
Thank you very much. All four presenters, please come here and read the comments, questions, and suggestions. Please come here. Okay, thank you very much. Now it's time for the audiences to raise questions, suggestions, and comments. So you can name the presenters, or you can use anything that indicates for the presenters and raise the questions. And any suggestions and comments related to the four presenters. Okay, one. Any other? So we can proceed from the raised hand, and then if there is anyone, we can act. So you can take the floor.
Good afternoon. Thank you very much, the organizers, for this timely item. I have also thank you for the presenters for your valuable contribution to the conference. My questions was to, I think, the one we presented on systematic and meta-analysis on terrorist violence in Africa. Given the title is response when crisis affected Ethiopia or Amhara regions, I expected that articles are included in war conflict. GBV in crisis affected securities were included in your articles. Had it been articles included, I think your pool prevalence would be higher than that of around 30%. So have you included any articles related to gender-based violence in conflict settings in Africa? So, yeah, obviously, the magnitude of prevalence in crisis times, in conflict times, is always greater than in enormous settings. So was your target lifetime prevalence or the general gender-based violence prevalence? So if it is a general one, we should include gender-based violence in conflict-affected settings, and have you include articles of that type? Definitely was for all of the violence, sexual, physical, emotional, all are in a hand. For instance, usually up to 70%. So have you included all of them? At least we do have just at least one article. If there is a one article, you should exclude that article and outlier in your analysis. This is the first question. And second question is, I think it was very nice had it been the prevalence rate was separately provided. That means you have a general pooled prevalence rate of gender-based violence in Africa. Another, it has a different implication if you had sexual, a pooled prevalence of sexual violence in Africa, a physical gender-based violence pooled prevalence rate in Africa, similarly emotional as well. So what makes you difficult to have a separate pooled prevalence rate of sexual gender-based violence, physical as well as emotional gender-based violence rate? Thank you very much.
Okay, thank you very much. Any other?
Thank you. አመሰግናለሁ በጣም thank you all the presenter and the moderator. Yeah, it is directly related with the theme of today's conference. Yeah, starting from Yimar's presentation is very nice. It has direct protective factors against burnout and secondary traumatic stress, which is very important for us to act on the issue because we are living with the issue of gender-based violence, sexual violence, yeah, considering morning session as well. So I've seen from presentation that if just for curiosity purpose, 43% have a high satisfaction, something like that. This satisfaction is all included, I think, in correlation meta-analysis, or share meta-analysis. What is you saying on this 43% of high satisfaction, maybe on the service provider or service receiver? Yeah, because this was done on compassionate satisfaction of humanitarian and social service workers. Can you say something about the specific professional type, which is specific professional very important for such service, because which I believe that it may help us to consider those professionals to act on the issue compassionate satisfaction. Yeah, this is for email. For Gabriel, that umbrella is very important, which is the gender-based violence in Africa. Surprisingly, this was the finding, sexual violence at 1%, which is directly related to what we did before 3 or 4 months ago. We have one systematic review of sexual violence among night students in Africa, which is around 43%. How much the problem related, even though that really was on night students. But my point for Gabriel is on the recommendation, just as a comment, rather than saying the Minister of Education should do this. It's better to have a kind of a smooth action purpose. But you give that continental gender-based violence surveillance. Don't you think that there is no a surveillance that considers gender-based violence? Because as Amara Public Health Institute, we have a surveillance, gender-based violence, sexual violence, we have this kind of surveillance. But I need to know what is the intention to say continental gender-based violence. Who will be responsible for this continental surveillance? Thank you for that. I appreciate
the issue for the umbrella review. And even though it has a direct relation with the term that is neonatal illness, my point on that is 58.5% antenatal follow-up. May you have which part of NC? NC 1, 2, 3, 4, 8, just to say antenatal care follow-up, because it has an implication for you in your science. But as a recommendation, you recommend for Amaral General for 4 or 5 organizations. What could be the role of Amara Public Health Institute in this finding? Don't you think the Amara Public Health Institute will have any role on the NNM? On AEO, which is again, which have an indirect relation with today's term, perceived quality of life, contraceptive counseling, method, satisfaction, and switch intentions. So, quality contraceptive, I'm sure you will have an operational definition for quality contraceptive counseling. I think this is secondary data you take from PMA. How do you get the previous family planning method used? I feel that somewhere you have an interview, but the data is from secondary data. May it have a question that asks the client the type of methods they used previously from that secondary data. And one thing, how the ethical perspective, ethical issue, how to ensure that for having this secondary data, and how meta satisfaction has been measured. Cross satisfaction is another big issue. This thank you.
Okay, thank you very much. So, for the time being, I will add one question for each. For Lima's presentation, your study was done in crisis-affected area. So, what criteria or what mechanism that you use to identify whether the crisis is happening in the country? Is there any description, whether internal or external affected? The situation is considered. So, what criteria that you use to review papers from different angles of the world? And also, here there are different stakeholders. So, what practical suggestions or mechanisms or strategies you forward for the stakeholders to solve any problem related to compassionate satisfaction of the individuals? So that is for Limer. And for Gabriel, you try to conduct review of review. So do you believe that the primary review is already saturated in African context? So if you believe that, what is the criteria to say whether the primary review is saturated or not? And also here, the gender-based violence is directly related to the different sectors, including in Amara region. So, what practical recommendation or policy recommendations you forward for RP, Regional Health Bureau, and the Ministry of Health and other responsible bodies? So the review indicates that huge number of the victims. For Daniel, you said that there is no validated tool in Ethiopia. That's the staff member in University of Gondar already validates neonatal nearness criteria. So why not you use such criteria? I think the result will be different if we use Ethiopia context criteria. And also, you said that the management and pragmatic approach. So in Ethiopian context, which type of approach or criteria is suitable and sensitive for identification of this neonatal nearness? And also here you miss the quality aspect of the healthcare system. This neonatal nearness is related to the quality of the care that's provided in different settings. So why you miss the quality health service provision in hospital, health center, and other areas? Last, for Telau, you assess quality continuum of care for contraceptive utilization and you use generalized equation modeling. Do you check and evaluate the approach that the current Ethiopian health context? You use the model that the health professional applied the model currently in the healthcare setting. Did you identify any pitfalls for that model, counseling model? And what were such pitfalls or drawbacks of the model? And also, you use generalized this structural equation modeling. So, what were the proximal factors that directly affect the quality contraceptive data utilization? Because you use the structural modeling, so it is easy for the responsible body to apply first the primary or the proximal factor. So we should clearly indicate such issues. Thank you very much. You can give response from Dani to the last one. Thank you very much.
Okay, thank you. Let me start from the final one. Really, you are Universal Government is undergoing to validate its own classification criteria, but during the study period, those were validated at country level, and we decided to use the currently already endorsed and validated tool. And the second question, which is there for our context, we know that our community even doesn't remember their last normal ministerial period and has no early detection or early screening of ultrasounds. So for the time being, the better identification criteria will use management criteria one, but we can't oversee the pragmatic one. Related to the health system related factors, we have incorporated the health related system, health related factors, and among the variables, only the cartograph utilization will pass the BIF because of small observation, so we exclude from the analysis. Regarding to what's the role of Amara Communications Institution, really we appreciate the role of Amara Communications Institution is a cross-cutting role. It works in humanitarian, state surveillance, for emergency services, and the only institution stayed resilient during crisis was even እንግዲህ በአማርኛው ነገር ካለብን የአማራ መልሶ መቋቋም ምናምን የሚባሉ የክራይሲስ ተቋማትን ጭምር ሲዘጉ በጦርነት ጊዜ ስታንዳርዱን የነበረ ማኔጅመንት ኢመርጀንሲ ማኔጅ ያደርግ የነበረ ኢንስቲትዩሽን ነው። ክሮስ ከቲንግ ሮል ይኖረዋል። ኮሚት መደረግ ነበረበት ዊቴክ ዘኮመን ኤምሲ ፎሎአፕ we asked two questions. We asked them whether they have MC visit or no. If they have MC follow-up, how much MC visit do you have? And that is why it is associated with the outcome variable. Those neurons born from the mother part less than 4 MC visit has been associated with the when we say ANC follow-up, 80% of the ANC follow-up means in another way, whether it be one visit, two visits, or 8 visits, they have history of ANC visit. So the analysis compared with those neonates born to the mother whose mother were had ANC visit and not.
Okay, thank you. It's a nice question and valuable question here. The first question about operation of Pacific Equality and Contrast Council. Since this, there are 12 items to measure Pacific Equality and Contrast Council, and we didn't just dichotomize this as have good quality contrast, not. Rather, we conduct conflict explorative factor analysis. In this case, unlike the direction method that just dichotomize in section, this one gives wide spread, which item measures the outcome variable way, so that it does tend to define the important things to identify the items that measure the quality of contrast counseling, manufacturing that item is included. On the second one, that is ethical issue. The ethical issue is the ethical was given by John Kish at Shaw University. Since I don't have that one, so I need this okay. And the other one, how satisfaction measure, that's an important question. And it's the from secondary data, the measure is on 4 scale. So maybe it's important to put us in limitation. I will show you how this satisfaction measure, and if there is a tool that develop this one, it's better to put on a segmentation. And so thank you very much.
Okay, thank you for your comments and the questions. I will take the comments and I react on some of the questions. The first question is, why don't you do research in the contemporary Ethiopia, like crisis affecting settings in Amara region and others? This is an interesting question. Doing primary study with supported with qualitative is really important, or is really essential. But we have not used this in the current. We have not doing this currently due to the resource constraints or the absence of or lack of funding, as well as the current situation is the area of the city is not as such researchable due to the crisis. Doing community-based research is very important, but the situation is so difficult with the economical problems. The other is why don't you do the prevalence separately, like that for sexual, for psychological, or physical? That's the matter. Okay.
as inclusion እና exclusion criteria conflict setting ላይ የተሰሩ አርቲክሎችን ባለማካተት እየመጣ ነው ወይስ unfortunately ዳታቤዞችን ሰርች ስታደርግ ከኮንፍሊክት ጋር የተገናኙ አርቲክሎችን አልሰበሰብክም ወይስ ምንድን ነው? ምክንያቱም we are talking about crisis እና እንደዚህ አይነት አርቲክሎች አካተት ቢሆን ምናልባት ያገኘው ውጤት በዚህ ከፍ ያለ ሊሆን ይችላል። ይህ ሲሆን ደግሞ ኢንተርፕሬቴሽን ፖሊሲ ኢምፕሊኬሽኑ የተለየ ነው። ይህ የመጀመሪያው ጉዳይ ነው። ምናልባት ከዚህ ጋር ተነስተህ የፔሪየድ የወሰድከው አርቲክሎችን ከመቼ ጀምሮ የተሰሩ ፔፐሮችን እንደወሰድ ይገልጻል። ምክንያቱም ሪሰንት የሆኑ አርቲክሎች በዚህ ሊስት ላይ እንግዲህ ኢትዮጵያ አርቲክሎች አሉ አፍሪካ ላይ እና እሱን አበርከት ሁለተኛው ደግሞ ምናልባት እንግዲህ ጀንደር ቤዝድ ገቨርነንስ ስንል ፎርሙን የተለያዩ ናቸው እንደሆነ ከውስጥ ተጠቅመዋል። በተለያዩ ሬቶች ውስጥ ወስድ ሴክሹዋል ቫዮለንስ እና ፊዚካል ቫዮለንስ ለምሳሌ ተመሳሳይ በባህል እና ከውስጥ ተጠቅመው ሁሉ ስትሰራ ግን በእያንዳንዳቸው አልሰራም። ከየክየሙ ጥቅሉ የአርቲክሎች በአናሊሲስ በሲስተማቲክ ሊሆን ይችላል በናሬሽን እሱን ስትሰራ የሴክሹዋል ለብቻው የፊዚካል ለብቻው የሳይኮሎጂካል ኮንስቲቱንስ ነው ኢፌክቱ ለብቻው አልሰራም። እሱን እንደዛ ላይ ተሰርተው ቢሆን ክፍል እንዳልኩት ሴክሹዋል ሲሆን ፊዚካል ሲሆን ሳይኮሎጂካል ሲሆን የተለያዩ ኢንተርፕሬቴሽን እና የተለያዩ ፖሊሲ ኢምፕሊኬሽን ያለው እና ሁለተኛው ጥያቄ እንደዚህ በፎርሞቹ ከፋፍተህ ለመስራት ያልቻልክበት ምክንያት ነው?
This is an umbrella review, so the study subjects to study parts ናቸው አርቲክሎች ናቸው ሲስተማቲክ ሪቪው ኤንድ ሜታ አናላይሲስ ናቸው። ታይሙ ታይም ሪስትሪክሽን ወስደን ፍሮም ኢንሴፕሽን ቱ 2025 ነው ስተዲዎችን ያካተትናቸው። ስለዚህ ታይም ሪስትሪክሽን የለውም። ግን ሲስተማቲክ ሪቪው ኤንድ ሜታ አናላይሲስ ስፔሲፊካሊ ኮንፍሊክት አፕዴቲንግ የሆነ አላገኘም እሳቸው ማለት ነው። በዛ ምክንያት ነው እንጂ ቱል አድርገን የዛን ኢፌክት ማየት እንችል ነበረ ሰሩ እነዚህ ሴንት ላይ በመስራት ማለት ነው። እና ለዛም ግን ኢዲፒ ላይ ያሉ አሉ which are more related with the crisis ሌሎች አብዛኛዎቹ እንትኖች ኢትዮጵያ ናቸው ኮንቴምፖራሪ ፕሮጀክት አያደርግም እና ስናመጣው እነዚህ ስተዲዎች ስላላገኝ ነው ማለት ነው። our search was very comprehensive, so wide. For the second question, yeah, we try to do some analysis for the forms of violence, the sexual, psychological, the physical. The main movement we try to discuss, try to recommend, we try to go more, but the sake of the time, the episode PowerPoint, it was shortened. This is for you. For the other question, for Dr. Adam, I will take the comment, but who will be the responsible body for surveillance? We recommend this action for African Union and the United Nations. So these organizations or stakeholders will be the owner for the continental surveillance systems of gender-based violence in Africa. For the third question, I will take also the comment. What is your practical recommendation for the regional organizations like the Space Office, Ethiopian Public Institute, Regional Public Institute, and the like? We have tried to identify the prevalence in Ethiopia, that's 41%, the total prevalence of gender-based violence in Ethiopia was found to be 41%. So we try to also discuss and recommend this, the recommendations in the local contexts. So the health education should be taken. Education is very important to bring the behavioral changes of the communities, especially the perpetrators. And the Ministry of Health also shall integrate the gender-based violence, in primary health programs, as well as the Ministry also shall implement the gender-based violence. Should implement the substance use cessations, like the tobacco, child. So this substance should be cessated. So different programs shall be designed for this, because they are found to be contributing factors for gender-based violence. The other is the total community engagement is very important. Involvement of significant others, like that of the religion leaders are also the other very important aspect. Taking community awareness, these are some of the actions to be taken locally, specifically in our country, Ethiopia. This is what I have. Thank you.
Thank you. There are about 3 questions that have been raised by Dr. Adana. Thank you so much for your question. My former instructor at the University of Gondar. The question was that the reported compulsory satisfaction score was for the clients or the service providers. This compulsory satisfaction has been measured in 2 ways, using the proportional factor like the scale as an issue as well as the proportional rate. So in the proportional rate, there are 3 prevalence rates has been reported using low, moderate, as well as high compulsory satisfaction rate. So the 3% high compulsory satisfaction score has been reported for service providers. Since our meta-analysis studies has been concerned for humanitarian as well as social service programs, which is supporting these individuals or populations which have been affected by conflict or war. So the prevalence reported in PowerPoint presentation was service providers. And the next question is raised by moderator. What are the criteria to include your studies? So the criteria which has been used for the inclusion of the primary studies was if a certain study which reports compulsory satisfaction score among humanitarian or social service workers supporting primary traumatic individuals has been included for meta-analysis. So those individuals or humanitarian workers or social service workers should be support the crisis or any war-affected individuals who experience certain burnout or some kind of traumatic stress. So our criteria to include those studies was primarily on crisis-affected areas of individuals who was working or supporting individuals affected by these wars and conflicts. And the third question was about our recommendation for different stakeholders. As I said before in the presentation, some recommendations have been raised. And the first one is the peace support. As the panelists has been saying in the morning session, peace support is very crucial to improve compassion satisfaction service providers for those individuals, as well as peace support also very important for individuals who has been affected by war and conflict. And the second one is second recommendation is trauma-informed supervision. There should be a program or check which is concerned with supporting those service providers as well as and continuous monitoring or work-related stress assessments. There should be an assessment of work-related stressors in order to measure their adverse professional cardiac outcomes. So it's very important to account there is a continuous monitoring or work-related assessment. And the other one is psychosocial support initiatives. There should be psychosocial support initiatives, which is very important to maintain or sustain the health and the health of service providers, as well as those clients who have been affected by war or any conflict. Those are our recommendations. Thank you so much.
Okay, thank you very much all the four presenters for sake of time. Thank you for your patient presentation and good response for all questions raised. If there is any left over, we can discuss during the poster show time. If there is any concern from the audience, you can get them individually and discuss and improve the paper. So let us give our hand for the presenters. Thank you very much.
ከዚህ በኋላ ያለው ጊዜ የፖስተር ፕሬዘንቴሽን ስለሚሆን አቅራቢዎች ለፖስተራቸው ጋር ተወዳቸው ማለት ነው። እሱን ጨርሰን ወደ ቤታችን እንሄዳለን።